You're listening to Ride Along, EMT School. I'm Mike.
And I'm Max. We're two students navigating EMT school, bringing you along week by week.
And I'm Jonathan, paramedic, bringing real-world perspective.
Join us as we share the lessons, challenges, and stories from EMT school, and hear insights from those already living the EMS life. Welcome to the Ride Along. Learn to save a life.
That's a good song.
Are we going to do this every time?
Every time.
Yeah, we probably are.
I think
People are so sick of the song
I have
already.
no doubt.
I'm sure of it. But welcome, everybody, to Ride Along, the EMT School podcast.
I'm back.
Max is back. Wait, is this? We did other episodes with you back.
Yeah, you were here last week.
We did last week. We did like 3 episodes.
We did. I'm
You
sorry.
were out for 4 and 5. We
Yes, what he said.
did. Yeah. He's still reeling. He was in fever dreams for
Oh my God.
for like a week.
It was
Coughing
it was-
up a lung.
It's like, do I have tuberculosis?
Yes, but that's besides the
Is that
point.
what I have?
Well, I mean, it's good though because look, we got to learn. You got to see firsthand respiratory symptoms,
Oh yeah, yeah.
which is, I mean,
Right. It was
what a
perfect,
segue,
perfectly
honestly.
timed.
Because tonight we're talking about airways, respiratory.
And ventilation, airway management, ventilation skills.
The title for tonight's episode is "And She's Buying an Airway to Heaven."
You know you like it.
Oh, man.
I got to be clever with the names.
I liked it. It
I
was
need to
good.
find fun. You know,
100%.
I love the pop culture references in the EMS world.
In general.
I find this is what I like most so far about playing in the EMS space. Stories. Like I love people who have good stories, and the EMS is filled with story. Like the whole communication like between people is like, oh, I was on this run, I did this thing, you know, this guy, this crazy shit happened, all the, you know, you have those things. And then I love the fact that it is a I mean, it's a blue collar field, right? Like people communicate in real terms. Like
Yes.
they are no bullshit. They will tell you they're no bullshit. I'm sure there's differences in culture wherever you go. But for the most part, I've seen this thing kind of being like people communicate real.
Yes.
And I love that.
Yes, 100%. And it's not hard to get them to tell you their stories. They pretty much volunteer it could you tell me? And like, they're already going.
Oh yeah. They want to tell you the
Yeah,
story.
they want to tell you.
That's all factual.
Yeah.
And I mean, like, even being on this travel contract, I mean, like, it wasn't long before, you know, we started swapping stories and very much that like, all right, we're gonna go ahead and just, you know, we're talking to each other like you know, like folks do in this blue collar trade. You know what I mean? Just no BS.
Well, to me, so I've spent far too much time in the quote unquote corporate world.
Yes, you have.
I despise it.
For good
I
reason.
make no bones about it. It is not a culture that I identify with. I love a culture that gives each other shit.
Yes.
Like that is my love language. Like making fun of you. If I'm not making fun of you, that means I don't like you. And
It's true.
Like I mean, really, your closest friends, you give him shit. Like I give Max shit all the time. But when he's not around, I usually speak pretty highly of him. I just don't like him to know
So
that.
he says.
So I say. It's when it's like that kind of talking to somebody's face and being like, shut up. You know, like just giving them the business.
Yeah,
And just,
exactly.
I love that.
Yep.
You do have to have a little bit of a thick skin for that kind of you know, that back and forth. And you got to be able to take it and you got to be able to give it.
Well, the people that can't take it generally, they're the ones that you speak politely to.
And that's true.
That's what happens. Like, oh, you're sensitive about this thing. Oh, you're being serious.
Give him room to talk.
No,
I'm giving Max shit right now.
See, I was physically assaulted on camera.
If you're listening and you're like, you know, dipping your toes in the water and you're like new into public safety and EMS, and you know, like maybe you're doing a clinical ride along or something like that. The crew's gonna like, you know, probably be buttoned up initially
Mhm.
and mind their P's and Q's. And then as the day goes on and they get to know you, if you're a chill person, they're gonna let you see how they actually are.
For sure.
And so and that is a compliment
Oh, yeah.
to you being a chill person. But yeah. So you just, it takes some time. And as people get comfortable with you, they're gonna show you who they are.
Yeah.
So
Yeah.
As a matter of fact, I know we're kind of getting off topic already because I know we're going to talk about Airway stuff tonight. Quick story, because we love telling stories, right? I had my first ride along last week. Uneventful day, right? But what I really got to experience was, so we had one call throughout the day. That call wound up being basically canceled as soon as we got to the front door, went back, and we just kind of BS'd at the house all day. And it was fun, learned a bunch, got to do a truck check and all that stuff. When I got home, my phone went off because I still had the app on my phone, that like the pager, right?
Right.
And I saw, pa-ting, a possible overdose at the local high school. I'm like, oh, well, that's interesting. I wonder what that was about. So I put it aside, and then I got a call or a text later in the day from the lieutenant, and she said, hey, your ID badge is ready to be picked up. Okay, I'm going to be right over. Because I'm like, well, if I pop over there, I know she went on that call. And like, it was like, I was already in the crew, right? Like I was there all morning. We bullshitted a bunch, and we got to swap aspirations and history and story, what we're looking for. So we got to know each other. And so when I showed up, I was like, hey, so what I missed? She was like, oh my God, you missed a shit show of a call. Like everybody was going crazy. And like, there were like 17 assistant principals in there with a kid that's losing his mind. Like I was like already one of the gang, right? Like, oh, you really missed it. So that's the best part. Like to be part of this thing, and to be kind of like, all right, well, yeah, I'm accepted, right? Like I felt accepted.
Right.
That
like whenever we go train, the best part of training is the before and the after. A lot of times of being able to hang out with your people, and like that's just the best part.
Yep. So, yeah, I think it's great. I love this stuff and the pop cultures and like how everyone kind of uses that as a communication tool and like references, movie quotes, like, phrases. It's very non-corporate, which is awesome.
It is fantastic.
Something to be said for it. For sure.
Yeah.
As far as like getting involved and, just getting into the culture. Like that's, and people may be hesitant to do that, but you really got to get in there and mix it up and start to engage with the folks you're riding with, because I mean you're gonna like truly you got to be able to trust these people.
Yeah, sure. You're in the trenches.
There's a big aspect.
Yeah.
Right, and that's what brings you close. You got to be able to trust these folks.
Yeah, and they need to be able to trust
you.
Talk
About everything.
Yeah,
for sure.
So,
well, before we get too much further into the episode,
sure,
I would be remiss if we do not take a pause real quick and mention our sponsor for tonight's episode.
Yep,
we should do that. So this episode of the Ride Along EMT School podcast is brought to you by Iron Forge Consulting Group, your source for tactical medical, firearms, combatives, and crisis intervention training. Iron Forge is an industry leader in tactical medicine. Their courses offer an engaging mix of academic material and hands-on practical skills, including scenario-based challenges that prepare you for the real world. Whether you're looking for a one-day class or a multi-day certification, they have options that fit your schedule and budget. And every course is taught by a cadre of experienced professionals using evidence-based methods designed to keep you alive on your worst day. To learn more about upcoming classes and to sign up for training near you, visit bulletin.net, that's bulletn.net, and search for Iron Forge Consulting Group classes near you. Yeah, so Jonathan is the owner of Iron Forge Consulting Group. Max and I are both proud alumni of his school. It's great stuff.
Yeah.
You should really consider taking it. It is probably, I think, the best bang for the buck that you could possibly do before taking like a more advanced long-term course like we're going through, like that type of training. And Jonathan does it really well.
Yeah,
So
as an instructor, I cannot say anything but fantastic things. Just the way he gets the information across to you, how he presents it, I cannot recommend it highly enough.
yeah.
Thanks, fellas.
You're welcome, sir.
I appreciate it.
Well, thank you
And
for being a part of the podcast and for sponsoring the episode.
110%.
Yeah.
And if you're listening and you would like training, like Mike said, go to bulletin.net. And we travel all across the country, so we may have a class near you. So.
Yes. So this week,
Topics covered this week, we're talking about airways and breathing.
that doesn't sound that
It's
important.
not that important, right? I mean,
Right.
what do you have, like 3 minutes before your breathing not happening is a problem? So it's like 3 whole minutes.
Yeah, it's the rest of your
Right.
life.
Exactly.
We went deep this week into airway stuff. Or actually, I think this is a combination of multiple classes because
Yes.
it was a lot of there was a lot of repetition
There was about, I would say, at least 2/3
repeated
of
between both classes.
So like the first section that we went through, and then it was almost like, okay, they took the last 2/3 of that chapter and put it in the next chapter. So it was good because it's important.
Yeah, it's almost like it's important to know anatomy and physiology, which was a lot of the overlap between the airway section and the respiration section.
So it was good.
Yeah.
But yeah, it was definitely, I really was surprised at the portion of the textbook that was taken up by that compared to some others so far.
Well,
But again, there's
a reason it's the A
yes,
in ABC.
exactly.
Airway, breathing, circulation. Right? Like actually it's airway and breathing. It's the first two. It's 2/3 of the most important thing that we think about. So like when shit is happening,
Yep.
if you're trying to make sure a patient isn't dying, you need to worry about airway and breathing first.
Right. And not just that, but like you being able to keep that patient from getting worse, like intervening early before it's an issue.
Yeah.
I mean, that can be the difference between, a simple case with a patient or where they're crashing and you're getting them to the hospital. Mm-hmm. So,
And that's an excellent point, Max, because I've seen people where if you don't recognize that impending airway failure, you're going to be dealing with it behind the 8 ball, and that's not where you want to be. I promise you. Mm-hmm. So early intervention with anything airway or breathing related it's got to happen.
Now, speaking of early intervention, warning signs, I think that's a good segue into our medical term of the week, which for this week is it's the name of a sound
yes.
called stridor. But did you know that the term stridor was first formally documented in medical literature in 1954, and that was, get this, the very same year that J.R.R. Tolkien published The Fellowship of the Ring, the first in the Lord of the Rings
So you're
series.
trying to say there's a correlation between the character Stridor and
Well, medical school instructors at the time, many of whom were Tolkien fans, began informally referring to the ominous airway sound as Stridor's call.
ooh.
And the shortened form of Stridor stuck. So yes, every time you hear it, you can thank Aragorn, the King of Gondor, for being the inspiration for the dangerous lurking figure known as Stridor.
Nice.
The one true king of Gondor.
Mm-hmm.
Exactly.
So the sound signals that things are about to get way worse, like when he fends off the Nazgul on Weathertop.
So if you can't tell,
This is total bullshit. I was just trying to see if I could come
Nice.
up with some convoluted story on what Stridor is.
again, pop culture references into the podcast, which are entertaining.
I'm a nerd. Like, I'm definitely a nerd.
Oh, yeah.
Yeah.
If you haven't seen the extended cut of this movie, it's like, what are you doing?
Oh, yeah.
It's so much better. so
Yeah,
much
if you want to
better.
kill,
A day.
10 and a half hours of your life, watch the extended cut of all the Lord of the Rings.
I have watched them back to back to back multiple times.
I have too. It took me a weekend the last time I did it. Like it was a commitment.
I started at 9 a.m. I ran straight through.
Yeah, but anyway, so
Anyway.
Stridor is not related to
So
Lord
what does
of the Rings.
Stridor
in any
sound
way.
like?
Well, it sounds like it's a high pitched or shrill noise, usually on the inhale. So I actually have an audio sound, and Jonathan could probably tell us if this sounds accurate because I'm sure have you heard it in the field?
Oh,
before?
yeah.
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 Seems to be one of those ones that pops up, and if you hear it, you'll know it, and it's important to know very quickly. So here's the audio file. Which kind of breaks your heart because you can almost hear somebody struggling. Like they're having trouble breathing. The airway is so narrowed that it's causing like a whistling sound.
Yep.
And usually that is somebody who's struggling, and like struggling to breathe is a nightmare.
The first 4 years of my son's life, he was a lot of times on nebulizers if there was any kind of sickness going, because he immediately went to that. And I have heard that far too many times while holding him in my arms, and it's not good.
It is a common sound with pediatrics. Yeah. So it's that kid's sick. Like that, if you hear that kid is sick.
Yeah.
Yeah. And it's interesting. Like, so I did not have any data on that particular audio file. It sounds like that's from an auscultation, like from a device that's actually listening to the lungs. It didn't sound like it's like a microphone in front of their mouth, which may also sound different.
But that's one of the sound, the breath sounds that is audible.
Yeah.
A lot of times, especially when it's pretty bad, it's audible without a stethoscope.
Yeah. And that's the point that I wanted to make, is that like, as we're going through this, we're starting to practice with stethoscopes for things in terms of vital signs. But I do know that there is going to be auscultation, or using of a stethoscope to hear these types of sounds, either through that type of observation or just hearing it. Sometimes they may sound different. So that's just calling that out to say, I think that's an auscultation, as well as I have a few other examples here of sounds that were talked about a bunch in class. So while Stridor is like, that's probably one that they mentioned twice as much as any of the others.
For sure.
And I'm picking up that it's probably because it's, when you hear it, it's like like you need to start addressing it now, especially because, like you mentioned, it's in kids, and kids with airway stuff. You need to make sure that's being taken care of immediately. So basically it's a hallmark of an airway obstruction. Now there's other sounds too. There was 5 or 6 that they had mentioned in class, one of which is snoring, which I don't need to play a sound of snoring.
No, we all know what that sounds like.
We all know what snoring sounds like.
Certainly our wives do.
My question is, though, Jonathan, is the snoring that they reference in EMT training essentially the same snoring that you'd hear when somebody's sleeping?
Yes. So, I mean, and typically it's an occlusion by the person's tongue. Yeah. And by, their anatomy. And so that's what's happening a lot of the times. Now it is primarily a thing we'll see with people that are less responsive.
Like unconscious.
Like unconscious, yeah,
and not with their head in like a proper orientation because their tongue or their soft palate hasn't been pulled out of the way.
Right, and that's primarily the thing. So, positioning is a big deal, and I mean, like even in somebody that's got sleep apnea or something like that, positioning is a big deal, and that's oftentimes why you'll hear snoring, because if somebody shifts positions, that'll alleviate some of that occlusion.
Right. So that's an occlusion of the airway. That's one that most people are familiar with because like 90%
Yeah.
of people snore in some way, shape, or form. Or it seems like Stridor we just talked about, which is a big one. Gurgling. This one sounds terrible. And that's enough of that.
Yes.
So that is the sound of liquid
Yep.
filling the airway.
And that could be blood. It could be a lot of different things.
Could be vomit.
It could be vomit.
Vomit. Yeah.
Yeah.
I'd say, based off of the conversations that we've been having around school and
Lots of vomit.
like I think
Lots of
vomit
vomit.
is going to be like
Lots
a
of
thing.
vomit.
Like it happens a lot, I guess.
Yeah. It does.
Things
And
no one tells you.
Especially when you start, manually ventilating people, maybe prior to having an airway adjunct put into place, or depending on what kind of airway adjunct you have put into place, it's very easy to get misalignment and start pumping air down the esophagus into the stomach, and eventually, your stomach's only got so much room. You pump it full of air. What goes in's got to come back out somewhere.
Yeah.
So, unfortunately, it is a part of ventilating. You got to be prepared to deal with.
So yeah, that was one of the sounds we talked about. Wheezing.
Mm-hmm.
Let's see if I can pull this one up.
That's another one I'm familiar with. I mean, when that's happening, it's almost like it almost sounds like there's a musical instrument in their chest. Like with my son, like it literally sounded like he had some kind of a woodwind in his chest because it was an odd tone.
Yep.
That's probably the one that I hear the most frequently in the field is wheezing.
Is that typically on the exhale? Like
Yeah, expiratory wheezing.
Expiratory wheezing. Yep.
Yeah.
And I'm assuming allergic reactions, asthma attack. I mean, like there's
swollen
fill in the
airways.
blank, emphysema.
Yeah, and you can get with asthma, which we're gonna get to. Mike's gonna go through all the sounds, but you get some rhonchi with asthma as well.
I have rhonchi right
He
here.
does indeed.
Yeah.
Occultation.
That's an interesting one.
That is.
It sounds ominous, like
It
you're
does.
listening to the ocean.
Yeah.
Yeah.
And then the last one
That's
is
the most bizarre one.
rales and crackles,
Yep.
which they say sounds like Velcro ripping.
It does a little bit.
The crackles, you can get subcutaneous emphysema, right, where you get air into underneath the skin. Excuse me. You get air underneath the skin, and when you're listening to it, it sounds like if you were to put milk in a bowl of Rice Krispies, and the air starts releasing out of the Rice Krispies.
That little crackling. Yep.
Yeah, the crackles. Yeah.
Yep. So those are the I would bet there's more, but those were the kind of like big ones that they had mentioned in class. And the reason I put them in here is because I think it's like it's an audio podcast, so it's the natural like place to put audio sounds that people can listen to. But B, like when you're in class, it's one of those things where it's like, well, you mentioned a sound. I didn't get to hear the sound. So I looked them up and I'm like, you know what? Let me put them in here so that people can actually hear what these things are, because you want to put a sound to the word.
I was kind of surprised, and quite honestly, like you said, they mentioned Stridor quite a bit. They kind of glossed over the others.
Yeah.
And it's like, okay, I get it. Stridor is maybe, in the wheezing is probably the most common, but it's like the fact that they didn't go forth and get the sounds that took you, I'm guessing, not terribly long to find. So we can actually
It took me a while. I had to pull
never
them
mind,
from a bunch of different sources.
Yeah.
by the way, shout out to EMT Prep on YouTube. That's where a bunch of those came from, was the playlist on there. And then one of them came from a soundboard, like that. It's just like a general soundboard. I don't even know where it's from. But it's sometimes it's just taking the time to kind of pull those things together to say, hey, this might be helpful to kind of hear the words that we're talking about.
It's funny. It's funny because this conversation has to do with the EMT tip of the week.
Oh,
so,
nice.
Yeah.
Look
So
at that.
when we get to
Look at him.
Synergy.
when we get to that, we'll kind of reflect back on this conversation.
Nice.
Sweet. So yeah, that's all of those are related to the medical term of the week, which was stridor, which kind of lends itself to talking about other airway impingement sounds.
Yeah.
So
And whether
things to listen for.
and whether you're training to become an EMT or you're just, like in my case, being a father of children, like it's important to know what those things sound like and what they mean.
Yeah.
Like, is this a thing where it's a minor problem, or like, do I need to get my child in an ambulance like an hour ago? So,
Yep. Well, now you don't have to get them into. Now you'll be the.
I'll bring the ambulance.
Yeah. You are the ambulance.
I'll back through the grape arbor and just right to the back door. And
Like you could just throw them in your Sequoia.
exactly.
Turn that. Now you could turn your Sequoia into like a makeshift ambulance.
Don't do that.
Is that,
Don't do that, Mac.
Oh, he's gonna do it. He's gonna have a stretcher in there tomorrow.
Not tomorrow.
If
but
you could figure out a way to latch a stretcher into the back of your truck using those Milwaukee pack out systems attachments.
no, they're too expensive. They're so expensive. So expensive.
Max is a big fan of those.
But anyway, so this brings us into the class topics.
Yes.
And the fact that they really were putting airway as that number one priority, like that thing that you need to address immediately. And I think it also lends you to understanding what's going on with the patient. The whole idea of being a detective and doing that initial assessment and like, okay, this is the first. It's audible. It can be physical. You can see it. And I think that's huge.
Yeah, and I think this might have been a topic that we've touched on in other episodes as well. The fact that as an EMT, you have a lot of responsibility, a lot of ability to help with the treatment paradigm, if you will. But this is one of those instances where like certain airway problems can be fixed by an EMT, in the moment.
Yeah.
And there's not a lot of those types of things that EMTs are empowered to do through scope of practice, right?
Yeah, it's a clear thing that you have the ability to fix.
Like if a patient's supine on the ground and they are having trouble breathing and they're unconscious, something as simple as putting or giving them a head tilt chin lift.
Yep.
Yeah.
Immediately opens their airway and allows them to breathe.
Yep.
Like you fixed a problem right there.
You're able to actually intervene on something where a lot of the stuff that's going on that you're seeing as an EMT, like you are limited.
Yeah.
Being able to, provide natural alignment of the airway, right? Those positional airways. It can't be understated how important of a skill that is. Because it in a lot of instances, just by positioning somebody, and I mean, like even something as simple as like, all right, I'm going to set the head of the stretcher up, and a lot of times that will fix people. Just getting their airway in a state of natural alignment, considering the situation they're in, it fixes a lot of issues. So it cannot be understated that just being able to apply that skill.
Yep. Just improving airway, through simple things. So that like everything is that's the simple side of it, to even employing some tools to then help with the airway even more. So we did a lot of practice with suction.
Yep.
This was our first kind of introduction into using that tool, a small vacuum with a basin on it that and with a Yankauer,
Right.
Look at him.
the Yankauer probe on the front, catheter, Yankauer
Yeah.
catheter,
Yeah, I've heard it pronounced Yonker,
Yonker.
but Yankauer, Yonker.
Well, it's I made sure to remember it because it seems like that's how people like it is a very it's one of those common pro words that people are like, hey, grab the Yankauer, and it's like I better know what that is.
Yeah, you should know what that is.
right.
Which is the tip, the type of tip that goes on the front of the suction device. And there's other ones too. There's like soft tubes and other
even
shapes.
larger diameter ones in case there is like actual solids in the fluids you're trying to get out.
But essentially, the Yankauer is kind of like the
That seems like the standard.
standard.
It's the one that we have used for the longest time. It does have its limitations. Personally, there's a device called a Ducanto suction catheter, and the diameter is significantly larger. The kind of thought process is hey man, you can suck a spaghetti dinner through that thing, and it's great because when you do have large particulates in whatever liquid you're trying to suction out of an airway, you need something that's gonna get those particulates, whatever they may be. And but yeah, I mean, I think across the board, a Yonker is what most places still have. In the departments I work at home, we have shifted that paradigm to include that Ducanto first and foremost. But we still do have the Yonkers available to us. But my preference is that Yonker.
And they mentioned that in class too. The Ducanto, right?
Ducanto,
Ducanto.
The one instructor he was like, there's this one, but there's this other one, but it was invented by this guy named Decanter, and he invented a tube, and it has a larger diameter. So.
And it's it's utilized very similarly, whereas the Yonker has a small hole at the back of the suction catheter that you must occlude with your gloved finger to pull suction. The Ducanto does not have that. It just has a hole it has two holes at the tip of it. So hopefully you don't like pull suction and get it caught on some tissue and then it like gets stuck. That's to prevent some of that.
Got it.
But that hole at the back of the Yonker, it alleviates that as well. So
yeah. So along with the actual tools themselves and the different types and attachments and stuff, we learned the proper suctioning technique. Of only going as far down as you can see and then suctioning on the way back out for a maximum of 10 seconds. Also, there was a good amount of discussion about how that's probably not what the real world is going to show us, but we need to know that because that is the proper technique to do it.
Yeah.
Because if somebody has a lot of suctioning to do, they're probably going to be suctioning for a while. So like it seems like there's the book answer. And then there might be like...
And I think it's across the board. I mean, it doesn't matter what's suctioning or anything else. We're going to find out those things you're using on the street. And you're going to get preferences depending on what that trainer has done or not done.
But it seems like that's one of the ones that they were pretty clear about in terms of like, this is the answer you need to know for the book.
Yeah.
Insert that thing as far as you can see. And then suction on the way up.
And then we had the adjuncts, the OPA and MPA.
Yeah, and that was, I think those are really interesting. So NPAs we've had a bunch of experience with. I've had one put in the past. I've put them in the past. We've done that with the tactical medicine side of things. OPAs we haven't messed with before, and I was actually kind of intrigued by them. I thought they work really easily.
They really do the job of getting that soft palate out of the damn way.
So let's take a step back because we're using some pro speak.
Oh, you're right.
You're right.
Yeah, let's tell the audience what an NPA and an OPA are.
Yeah, so an NPA, a nasal pharyngeal airway, is a tube that gets inserted up through the nose and it goes back down through the nasal cavity into the upper airway or upper respiratory system, and it goes behind the tongue. So essentially, it allows airflow without having to physically move the tongue out of the way. Right. The oral pharyngeal airway is a plastic hook-like object that gets inserted into the mouth with the hook facing up. It gets inserted in and then rotated so that hook pulls the tongue out from the back of the throat, opening up the oral pharyngeal cavity, right?
Yes.
So, and allowing air to flow.
Yeah, it's also got channels through it so air can pass through.
Right. Yeah.
Right. And I mean, and the nasal generally is used for conscious patients, the oral for unconscious.
Yeah, so nasal airways are tolerated by conscious people. It's not a fun thing to have. Mike, I know you've experienced it. I've experienced it. It's definitely tolerable, but the big thing is, do we have a gag reflex or do we not have a gag reflex? And if we have a gag reflex, that's why we would choose a nasopharyngeal airway over top of an oropharyngeal airway.
Right.
It really comes down to that ability to not initiate a gag reflex, because we don't want to contaminate our airway that potentially isn't contaminated by causing somebody to gag and vomit. And that creates a whole slew of problems for us. Mm-hmm. In my experience, if we know that somebody's probably going to wake up, through whatever we're doing, whether it's moving them or whether it's it's potentially an overdose, we may want to go ahead and start with one, being the MPA. If we think we may encounter a gag reflex, if we're working a cardiac arrest and we start out with that OPA, that's probably an okay thing, and we're probably going to transition that anyway to an iGel at some point, depending on the level of our crew and the care they can provide. But that's the big distinction: gag reflex or no gag reflex.
Yeah, right. And there's nothing to say that you can't then put all of them in. If you felt like that was something that would help you secure an airway even further, having an oral pharyngeal airway in, and then even two nasal pharyngeal.
Because you do have two nostrils.
You have two nostrils.
Yeah. In my career, I have done an MPA, like put an MPA in somebody, and then also came right behind and put an OPA in somebody. Mm-hmm. They were having snoring respirations and they did not have a gag reflex, and it did benefit us in ventilating them.
Yeah.
Right.
So
and basically what you're doing is, and I forgot to mention this at the beginning because there was a constant set of two questions that they kept hammering home throughout this class, which was the basis for everything of the night or of this topic was, do they have an airway? Like that's the question number one. Like, what do we need to do to make sure that they have the airway, and then will it stay open? Those two questions need to be asked constantly. And if they have the airway, great. What can I be doing to make sure that it's going to stay open and be more definitive? In the long term. So, and I think this is a good point to talk through, like the fact that airway, like these kind of adjuncts, right? That's one of the distinctions that we get from the BLS versus ALS side of things, right? So on the BLS, the basic life support side, EMTs, generally speaking, I'm not sure if this applies everywhere. And then once you go to advanced EMT, that's a whole different ballgame too. But basically, you get everything up until something that would be considered to be quote unquote invasive.
Right.
So
non-invasive treatment.
So we get to do the oral pharyngeal airways, nasal pharyngeal airways, things that get placed into the upper respiratory system, the upper airway. And then when it starts getting down into the lower airway, past the epiglottis, that's typically where there's a kind of tipping point between things that are considered to be BLS versus ALS. And then there's one set of things too that kind of, like, it depends on where you are, like that. So like you have the oral, the adjuncts, and then kind of beyond that, you start getting to supraglottic airways, right? which are things that go down far enough to cover the trachea. Am I right?
Yes.
Right. And basically seal around the trachea to allow a more definitive airway.
Right.
And then beyond that is
it would be intubation, right?
Mm-hmm.
So endotracheal intubation, right? We are inserting a tube down through the upper airway, kind of moving the anatomy out of the way with a laryngoscope and visualizing the vocal cords which sit at the opening of the trachea, and then passing a tube through those vocal cords into the trachea. The tubes have a inflatable cuff that allows them to be secured in that airway, so you're not just gonna, hopefully pull the tube out. You still have got to be extremely careful in securing that tube and making sure that you're controlling the airway when you're doing intubation. But yeah, so that is definitely like a more. There's a lot more to that. The kind of the difference is process with the simple adjuncts like the MPA and the OPA. I would ask some questions like, okay, OPA, do I have facial trauma, potentially, head trauma that's going to cause issues, fractures on the inside of the head that could potentially cause some issues if I insert this MPA, and if it doesn't check that box, then we're good to go. And then like OPA is like, do I have a gag reflex? Okay, I don't. I can use this. So very, very like simple determinations that you have to make to utilize those devices. And then your supraglottic airways, they same sort of deal. Another term for those airways are BIAD, which is a mnemonic or an acronym. So BIAD, blind insertion airway device. So we are not visualizing anything. We are using sizing guidelines for these different devices to kind of secure them and get them where they need to go
for
and feel
insertion.
Yep.
I watched a bunch of supraglottic airway insertion videos. Just because that was a completely new topic to me coming through EMT school. I was aware of adjuncts, had some experience with those before, and I was aware of intubation because I watched a bunch of ER as a kid. Awesome show, by the way. You should, anybody who's interested, by the way, total side note, you should watch The Pit.
You should watch The
Pit on HBO Max. Like, it is a really, really good medical drama with that's widely been recognized as some of the most realistic medical stuff that you could possibly imagine.
It was great.
So sorry, side note. So I learned about intubation as a kid from ER, but like supraglottic, never heard of it before. It was not completely unaware until 2 weeks ago.
Right.
Yeah.
And oftentimes, depending on where you are, you have some sort of supraglottic airway or blind insertion airway device as like an intermediary between those adjuncts and that endotracheal intubation. And a lot of times that is an EMT level skill using those supraglottic airways. It all depends on your protocols and and what your
currently,
medical
fun
directors
fact,
are gonna,
yes, currently in PA,
we are not allowed to do any supraglottic or blind insertion devices. Unfortunately, I think that's a shame. After seeing how they work and understanding them and seeing where they fit within this paradigm of helping secure airways, I think it would be remiss of Pennsylvania, if I can get on a soapbox for a second. And,
sure.
I think this is one of those things that like you guys should probably reconsider because
100%.
it is certainly a skill that I think that we have the capability to do safely. That's the key thing. And it seems to have a huge benefit. But I'm just a layman. Like I get it. There's probably a bunch of liability and possibly contraindications concerns that doctors worry about, like that they are most familiar with. But I think it's like widely seen, and it's a national registry EMT skill to understand and know about supraglottic airways. So we should probably be able to do those.
And in the tools of trade section, we're going to actually go over one of them.
Yes, exactly.
It's one of those things. And in Virginia, we've been doing. I mean, there's been some sort of blind insertion airway device that has been available to EMT level providers for quite a long time. When I first got out of EMT school, the device in question was called a King Airway, and it had the cuffs kind of like an endotracheal tube, and you had to inflate them with this big syringe, and it was this whole thing. And I always, they're not complicated devices, but the process I thought took a little bit of time, especially when you needed an airway quickly. I just thought that they took way too much time, and there's a lot of this is process based and having everything kind of set up and ready to roll. But I just didn't think that particular device was as useful in that. But prior to that, we had something called the combi tube, and lots of devices out there. And again, most places include these blind insertion airway devices as a BLS skill.
Yeah.
So it is interesting to hear that PA has not gotten on the bandwagon, but that's the nature of EMS across the country.
Wow.
You've got pockets of places that just they're going to do different things. They think some things are more of a liability than other things, and other places are like, nah, we're doing this. We're getting all of our EMTs to do this thing.
Yeah.
Yeah.
So,
Well, maybe who knows?
Maybe this podcast will
can help spark
inspire
change.
PA's change.
Maybe the medical director for Pennsylvania will listen to the.
I mean, you're a dedicated Pennsylvanian. You now even have art on your skin.
I got a
declaring
Pennsylvania tattoo the other day. It's official now. But yeah, so lots of options. Oh, I think we would be remiss to not mention kind of like the one extra step that you as a ALS provider and a paramedic can go to. And I don't know all the details, but it's God, what is it called when you cut open the throat?
Or a surgical crike.
Surgical criciotomy, right?
Yeah, cricothyroidotomy.
Cricothyroidotomy.
Yeah. So
that's kind of like, if all the other ones fail, you can go to that one, which is really invasive.
Yes.
It is a surgical procedure in its namesake. Some would say, oh, airway of last resort. And I would caution them to say, maybe some patients are going to need that airway of last resort immediately.
Right.
That's going to be the thing that they need to have happen for them, depending on the situation.
What are like the basic criteria for that?
So any impending airway failure that's going to not allow you to intubate with an ET tube, that's typically it's going to be something like major trauma or burns that extend down into the airway or are in the face. With burns in particular, you're going to have significant swelling, and that's not going to allow you to utilize your laryngoscope. That's not going to allow you to use your ET tube. And so the solution to that is we're going to have to make an incision and go directly into the trachea with our tube, externally through that incision. And as an ALS provider, the big thing is, like, even when I intubate, I have options. So if I know I'm going to intubate, sure, my first line option is my ET tube that I'm gonna put in there. Next, I have a backup eye gel or a supraglottic airway available to me as a backup in case I'm unable to establish that ET tube. And then finally, we do have that surgical crike procedure with that. So if you're doing intubation correctly, again, going back to process, part of your process should be making sure you have all that stuff laid out, ready to just roll right into the next thing.
Right.
If you get a failed airway.
With also keeping in mind that you might need to jump right to the
Yes.
last resort, quote unquote,
Right.
if you need to, based off of what you're seeing, what you're assessing, and
Yeah.
I think that's kind of like what we really learned from this, because like our choices are more limited. And I think that's what's fun about kind of talking through, hey, there's all these options out there, but as the EMT, these are what we can do. We can work through these things. And even on the BLS side, or at the BLS level, I should say, is there are options available for like, hey, going to an oral pharyngeal airway. If that becomes no longer tolerated, then you can go to the nasal pharyngeal airway, and then you have options, right?
Right.
So I think that was a lot of the practical skills too that we learned in during those two classes. But that and the whole extra side too. So a lot of what we were doing was manual airway opening, right? Like jaw thrust maneuver, head tilt, chin lift, ventilation. So like then getting into, okay, if not only are you opening up their airway, but what if they are breathing so poorly or not at all that you then have to take over for them.
Exactly.
Which is another kind of big skill, something that I think is very much like associated with all of EMS. And that is like the ventilation side of, breaking out the bag valve mask and then, putting the face mask over somebody, holding that, and then breathing for them with the bag valve mask. That was a lot of the practice.
Yeah.
Sure. Mike, do we want to just real quick touch on just for a second? You're talking about a head tilt chin lift and a jaw thrust maneuver. Do we want to talk about those positional airways and
sure,
what we would, not really as a teaching point, but just kind of describe what those look like.
Right. So I think that's great, because I think it's going to be something that is so ubiquitous to like helping patients, especially those that are unconscious, that like they're going to be like, you do them almost instinctively at this point, right?
Right.
So if somebody is laying prone, like the positioning of their head is too far forward and their tongue and everything falls to the back of the mouth, impeding airflow, right?
Yes.
Right.
So what you need to do is basically align the neck so that the tongue is no longer hitting the back of their throat, allowing for the airway to open up. And there's two kind of ways to do that. The first one being the head tilt chin lift, right? So you're putting a hand on their forehead, you're putting some fingers under their chin, and you're gently bringing the head back so that you're aligning that airway to open it up. And it's as simple as just tilting the head, right?
And if to give you a visual, if we think about the positioning of the head, we want the nose to be in an upward position, like a snooty lady is turning her nose up at something, or maybe you smelled something and you're trying to sniff it on the air.
The sniffing position.
The sniffing position. Yeah,
yes.
that's pretty descriptive, I think.
Mm-hmm.
Yeah. But yeah, that's exactly right. We want a natural alignment of the airway, and to get that, we're gonna put them in that sniffing position.
And then with the jaw thrust, that was if you have indications that they may have some kind of a spinal injury, something where you don't want to necessarily move that neck from a neutral position, then you can put your fingers behind the back of the jaw and thrust the jaw forward.
Right. Pulling the tongue off of the airway.
Right.
Which comes into play too, especially if like you have a patient in a C collar, a cervical spine, a C spine, or a backboard collar or something in that nature, where you may not have the flexibility to lift their head up or tilt it back, or you may not be able to if they're in a C spine like collar. So being able to get a finger under the jaw and thrust it forward will help open up that airway for if you need to do ventilations or just to help them breathe better on their own. Right?
Yeah. And the disadvantage of the jaw thrust in comparison to the head tilt chin lift, oftentimes you're going to thrust that jaw forward, and as soon as you remove the manual pressure that you're putting in there to kind of keep the mouth open, it's going to go right back to
Right.
closed.
Yeah.
So that's a disadvantage of it. But yeah, if we're trying to maintain cervical spine precautions, right on. We want to use that technique. So
Yeah.
I just thought that'd be useful for the folks
for
to
sure.
hear.
Absolutely. And the head tilt chin lift is interesting too, because I think they had mentioned in class, maybe like class 2 or 3, we were talking about like body positioning. Even just propping up and putting some padding under their shoulders will bring their chest up, which will more naturally align their head. So you like, if you have a patient and you pad them in the right way, you may not even need to do a head tilt chin lift because their airway is naturally aligned by the way that they're laying. But typically you don't have the luxury of always kind of stuffing stuff under a patient's shoulders so that they're laying in a perfect way. So that's where sometimes you need to use body positioning to open up the airway.
But if you're on your own and you're doing this solo, I think it's a valuable skill to have. That way you can do the other things and that airway can stay in that open position without you manually having to do it.
Right. And so we talk, especially with pediatrics, we talked about padding under the shoulders because their noggins are so much bigger.
Yeah.
That I remember us touching on that, but even with adults, padding under the shoulders, and we for endotracheal intubation, we will do that, and we call it ramping, and that is to help aid us in getting that more natural alignment, so we can visualize a lot better, hopefully with that elevated position and that more natural alignment that we get. So it's good stuff.
Yeah. So that all led into, and like, there's really kind of two topics that we got into that we haven't really touched too much on yet in this discussion. That is ventilation, bag valve mask, proper seal, getting that around the patient's mouth and nose, and then incorporating that into either the head tilt chin lift or the jaw thrust as you're securing that the mask of the bag valve mask on the patient as you're ventilating. We did do a bunch of ventilations, but we learned how to do those in CPR training.
Correct.
So 1 breath every 6 seconds is the typical respiration.
And that taking that slow second to inflate the bag instead of it being
it's not a
like taking that time to get the air in, and also only doing so much as to see the chest rise so that you don't necessarily hurt the patient.
Right.
And then what seems to be a bread and butter staple for EMTs, oxygen.
We got to play with tanks.
We played with oxygen tanks for like 2 nights.
Regulators.
Yeah. We got to like, they put the oxygen tank on the table the one night and they're like, okay, change that thing out. Like, change the regulator. I'm like, I don't like, I'm pretty mechanically inclined, and I'm looking at this thing going like, I don't like, just from looking at it, did not understand it initially because there's like levers and like knobs and stuff on it.
That was my jam. I was like, yes.
Yeah. I mean, like
this is my jam. Okay. You've got a mechanical thing and I have to figure out how to put it on that thing and make it work. Got it.
Yeah. Max looked like he was like trying to hit the thing with the stick. No, I'm kidding.
Yeah, it like that was like, okay, cool. Like this is like the way I learn and my strengths in what I do. Like that's that thing of figuring out how to make my hands do things that I want them to do and work with things that I haven't seen before. It's just what I do.
Yeah, so the oxygen was interesting.
Yeah.
I've never played with it before. And then once you saw it, it's like, oh, okay, the regulator comes off. That regulator goes onto another bottle. That's how you switch out bottles.
Yep.
They connect to nasal cannula or a non-rebreather mask. Those are the two things that you typically see in in any type of medical drama. Yeah. The nasal cannula being a small hose that goes up into the nose and delivers oxygen straight into the nasal pharyngeal airway. The non-rebreather mask covers over the mouth and the nose, and then allows for the patient to breathe a higher concentration of oxygen because it has a big oxygen reservoir in the front. Man, I'm actually kind of impressed with myself in remembering a bunch of this stuff.
You got it.
And they're both indicated for different things. I believe The non-rebreather mask will have, you can get a much higher flow of oxygen, 15
That was the
liters
standard,
per
yep.
minute or higher
Yeah.
with the but most of the tanks would only go to 15 liters per minute. So that's like the mask, the non-rebreather mask, 15 liters per minute. And then nasal cannula can only handle, I believe, 6.
4 to 6. Yep.
Four to 6 max. So like that's it's one of the ones for it's like if you need a little bit of air and less invasive, you can use a nasal cannula.
And like little tips, like making sure to purge the beginning of the tank so you don't get dust and particles running down your tubes and people's faces and lungs. There's like little gaskets to make sure that they're in place so that you don't have a leaky tank.
There's some maintenance stuff that you got to keep
it was
in
great.
mind.
Like I love that stuff.
But essentially, like, you know, the oxygen being the thing that's like, hey, if they're in respiratory distress in any way, shape, or form, it is a pretty safe bet that you giving them oxygen can only help.
Yep.
Now, there are some stipulations to that. We did learn some things, and I will butcher the terminology, but I know the concept, and that is that if you over-deliver oxygen into the system, you can give too much oxygen to a patient, and that will take out too much carbon dioxide from their blood, right, or their respirations, and that can cause further problems. However, that's way less of a concern, it seems like, than not having enough oxygen in the first place. So it's kind of like it errs towards just give them oxygen and it'll help them breathe. And that word that we keep using, perfuse better.
Yep.
Perfusion.
Yeah.
And even with the BVM, you have the ability to introduce oxygen there. Even with the simple CPR mask, some of those have a spot for oxygen to attach to. So I mean, it's definitely something that we're going to get our hands on all the time.
Yeah.
You know, and we've kind of touched on it in some previous episodes, like the differences between now and how things were taught when I came through EMT school, right? If somebody needed oxygen, it was 15 liters by non-rebreather every single time. And that's just not the case.
Yeah.
So at this point, we have a metric to kind of shoot for, a goal to shoot for, right? We want an oxygen concentration or an SpO2 reading of 94% on whatever oxygen delivery device you're using at whatever rate you're giving it at. And so once we get to that 94%, you know, we're going to consider kind of staying there.
Yeah.
Now, if you continue and the person's still in respiratory distress and they feel like they still aren't getting enough air, then okay, we can continue to bump that a little bit depending. But yeah, so that target of 94% on whatever delivery device that we're utilizing is kind of where we want to be. But we back in the day, we never had the ability to kind of make that determination, at least from a testing perspective.
Give them all the oxygen right now.
Yeah, exactly.
All of it. Yeah. Every bit you have. 15,
All 15
liters.
But that was also important, the idea that you're continually assessing the patient. Like you're doing that assessment initially, but as you go through, as you transport, you're continually assessing the patient.
Yeah.
Their vital signs.
Is the airway open now?
Yes.
Yep.
And will it stay open?
Exactly.
And like there's more assessments that which I'm sure we'll go over in the next, especially the next couple episodes where we start getting into vital signs. Next episode is vital signs, and then the episode after that is going to be assessments.
Yeah, full assessment.
Initial assessments, secondary assessments, assessing. But the core concepts here are starting to be introduced, right? Like assessing the patient, giving them what they need, not just performing to a
robotic
level of execution where it's like 15 liters by non-rebreather. I'm actually regretting at this point not using respiratory distress as the medical term of the week, because I feel like that would probably be an important concept for people to understand. However, it's all the things that we've kind of talked about in terms of like signs that somebody is not breathing well is the things that you're looking for in terms of respiratory distress. right?
Right.
Difficulty breathing, position of breathing. If they're in that tripod position, like their hands are bent, they're bent over, their hands are on their knees. You know, a high respiratory rate that seems abnormal for the activity level. A low SpO2, or like, and I'm sure. What am I missing? Like other forms of respiratory distress.
Yeah. You know, you mentioned tripoding. That's a big one. Use of accessory muscles. So you'll see like somebody will have their muscles, like their neck veins are popping and they're just like
belly breathing, like
belly breathing,
like,
especially with kids. Yeah.
Or even that motion of like hunching back as their inhales are trying to get as much air as possible.
Pursed lips. So like if they're like when they're exhaling, they're almost like you're blowing bubbles.
I do that when I have a heavy like respiratory load. I tend to do that.
Yeah.
Like,
so and those people are trying to maintain their own PEEP, right?
Oh,
That's a term you guys are going to learn.
That's the carbon dioxide level in the.
No.
Oh, okay. I've
No,
heard PEEP. I did not know what it was.
Yeah. So positive expiratory pressure.
Oh, okay.
So they're trying to do is keep a level of pressure in their respiratory system to keep their alveoli open.
Okay. Yep. To keep it from collapsing.
Right, because that's where the gas exchange occurs. We see this a lot in COPDers.
Okay.
Right. Yeah. Let's see what else.
Cyanosis.
Yeah.
Bluing of the lips, of other places.
The nail beds.
Yep.
Yeah.
Poor capillary response. Right.
Yeah. Capillary refill. These are all signs that something is going on.
Those are poor signs of perfusion, which is going to be coming from the respiratory distress.
Right. So, but yeah. So. Yeah. And those do we see how this whole, like, at least on the airway side, how depending on what's going on, it could be airway, breathing, or a circulation problem. But in this instance, we're talking about how does that airway aspect of it affect all the other things, right? If you don't have enough oxygen, you're gonna start to lose the nice pink color to your skin. And it's got to start to turn blue.
Yeah, and I think this is the cool thing, and where we can start making connections between even episodes and topics and classes that we've been having, is because all the practical, the like, if you see this, you do this type of thing. It's all rooted in what we understand as, okay, well, it all relates to the pathophysiology that we were going through in like episode 5, and, you know, how all they play together and the body's compensating. And, you know, ultimately it's about perfusion of all the tissues in the body. So it's like, the airway is super important because that's where it all starts. And if they're not getting a sufficient airway, if they're not getting enough oxygen, all the other things will start showing signs. Yep. So respiratory distress is one of those things that was like ubiquitous to like the topic, right? Like showing signs that they're having trouble getting enough oxygen or just trouble breathing. And then that would lead to ultimately respiratory failure, which is where we get into some of the things that we just talked about in terms of ventilation. Yep. And like that's pretty much the nutshell. Like everything that we learned in a couple of different classes, it was a marathon, right? Like there were a lot of different things in those classes, and we got a lot of hands-on.
Yeah, I mean, we got a lot of practical training. Very much in some case, in a couple of cases, it was almost scenario based.
Yep. Sure. I do like the scenario based stuff that they put us through.
It makes it real. Like if you can make the training, in my experience, if you can make the training real for you as you're doing it, you're going to get much better retention of what you're doing, and it's going to be more meaningful. Yep. So I think anything where you have and having instructors that are creative enough to give you those scenarios.
Yeah. I think that's super important.
You guys are entering into the point in class where it's starting to click for a lot of people. you're starting to bring all these things because those first few classes, those first few weeks of classes, you're talking about history and ethics and legal, and you're talking about body systems, and it's like, okay, but like, how does this apply to what I'm actually like going to be doing in the field, right? It's the academic portion is tough to kind of sit through because most of us that are involved in public safety can't sit still.
Yeah.
Yeah.
So, but yeah, no, it's great that it's finally starting to like come together and you're getting those hands-on scenarios because that's the bread and butter of EMS.
Yep.
For sure.
So we're running a bit long. I think we tend to do that.
We do.
We like to get talking. So I think that gives a really good kind of wrap up of everything that we learned. And again, like this is another constant theme of the show. Everything that we learned, I'm sure we're going to keep learning and keep getting practice in. There's a reason they put Airways like very early on in the curriculum is because I'm sure we will.
It's going to be a constant.
It's going to be constant.
Thing.
Like everything that we do.
Yeah. Eventually, it's just going to be natural. Like this is what you're falling into. This is your routine.
Yep.
Right.
So with that, we have a tool of the trade today that is very related, and we even mentioned it a couple of times. And I think at this point, we're no strangers to the idea of what a supraglottic airway is. We talked about that before, and you have a specific one.
Yeah,
that is a very popular.
So this is called an eye gel, and I think the best explanation that I got when he were talking about it, it basically takes that mask of the BVM or your CPR mask and brings it directly onto the airway. So what you're literally doing is inserting this in, and this is actually going to come in contact and be that mask that makes a seal and delivers air directly into the upper airway.
The trachea.
At the glottis.
Well, it goes past the epiglottis to the trachea.
To the trachea.
The trachea is the entrance to the what's the tube that goes to the lungs? That's the trachea, right?
That's
the upper part of the trachea. Yeah. That little mask goes directly on that.
So it allows you to put that mask directly on there, and you're directly bringing air to that airway.
Mm-hmm. You're going right past the mouth, the oral pharyngeal area. You're going past the epiglottis right to the
and a couple other things. So up top here, there's actually a small tube that you can attach oxygen to, so you can put oxygen treatment directly into the lungs through this airway. Mm-hmm. It also is made in such a way that there's a bite block, so it keeps that mouth open. It keeps the airway correct. Also, what comes with this here, at least this one, it has a strap. So you would strap this around the back of the head, basically holding that airway in place. It comes with a little bit of lube so that you can lube this up beforehand, so you can get that in a little easier, a little more pleasant for the patient.
Well, it's and that is the prescribed insertion method.
Yes.
Like, you know, if you're using any types of tools like this, you want to make sure that you're going by what the actual like methodology is for, and that does require lubrication.
And a little bit of history is launched in 2007. It has 3 adult and 4 pediatric sizes.
How do you know which size to use?
By weight.
Okay. So what is that one?
So this is rated for,
I think it's on.
it might be 30 to 60 kilograms.
30 to 60 kilograms, but we're not in.
We're not, which is interesting.
We're not. This isn't Europe.
Yeah. So 60 to 120 pounds. So basically, that would be a child to small adult.
Okay.
So 120 pounds.
Small adult,
yeah. I mean, like the small adult is relative. I think that's normal.
True. Also, go ahead.
Yeah, here's something about the weight based application of those. These are ideal weights. Like if for your height, what is your ideal weight going to be?
Right.
So that's something to keep in mind. If somebody were 4'11" and 500 pounds, you wouldn't necessarily have to go up in size.
Right. You're really more going by the what is that term for the optimal height versus weight ratio?
Body
BMI.
BMI.
You're kind of using the BMI as a guide for. They mentioned that in class the other night that like I'm obese, right? Like you wouldn't. There's no obese
Correct.
eye gel.
No.
It would just be whatever the typical. It'd probably be whatever the largest one is, but like
you would be a size 5.
a size
just
5.
just based on your height,
Yeah.
you would be, both of you
Yeah.
would be size 5s because you guys are taller.
Yeah.
And your ideal body weights would be higher than somebody,
Right.
potentially shorter.
And a couple other things. So apparently, 2012, the indications for use were expanded to include a conduit for intubation.
Yeah, I've seen that. I've been taught that. How would you use it to kind of facilitate an intubation? There's some process to it.
Right.
Again, we kind of go back to with Airway. We go back to the process of things. There's definitely a process to it, but it is doable in a pinch.
Gotcha.
It's not preferred, but it's doable.
I think one of the other benefits of it that I remember them mentioned the other night is that there is a pathway where you can still get to the stomach.
Yeah.
So if contents come up, they can still come out through the tiny hole that goes down into the esophagus. Yep. And then that would also allow for like the passing of a tube for whatever you would need to do for that while keeping the airway in place.
So what Mike's talking about, as you look at it, if you're not watching this or you're listening to it, there's another tube that starts at this. There's 2 tubes that go through it, one for airway, one for the
Access to the
stomach.
Or the esophagus.
So this is widely used, and hopefully PA will decide that they will allow us to be able to use them in the field.
Well, it just seems like a really good
does.
option, a good thing to know, and based off of like the value for definitiveness or the amount of skill needed with potential downside versus the usefulness and ability to have a more definitive airway seems like it's a no-brainer. Like it's non-invasive. Like the insert, if you watch the insertion videos online, it's literally it seems to take less time than an oral pharyngeal airway, honestly. Like, if you're putting in one of those, there's a twist involved. That is just like you just stick it down in their gullet.
Lube it and go.
Yeah, lube it and go.
Yeah.
So I think it's cool. That's one that like a tool that like I was not aware of before taking EMT training, and I will certainly be aware of that and keep that in mind.
Yep.
There's some nuance to it. Again, we talked about ideal body weight. That's one thing. If we're using our securing strap, we can overextend that strap. And if we do, we can potentially unseat that eye gel.
Because it's going to pull it away from
it'll pull it away.
Yeah.
The way it was phrased to me, because so you've got little holes that go into hooks all along that securing strap, and then the securing strap comes around to the back of the neck. And then on the other side, it has another set of holes on the securing strap that you hook, and you pull tension in that, and it kind of secures it in place. So when you're pulling tension on that, you want the holes to be more like oval egg shapes, and not to flatten out all the way.
Okay.
So they flatten out, you're using too much force.
Got it.
And along the same lines as like if we're going to move people, we need to make sure we disconnect if we're not directly controlling that bag valve mask, we want to disconnect our bag valve mask, or our ambu bag from the top of the device, because it can just that like weight of that bag can unseat it.
Yeah. Because it's not secure, like it's not attached or
it's just sitting.
Yeah, it's just sitting right on the
relying on the anatomy to hold it in place.
Yeah.
And couple more quick ones. I think that it's super neat. This is neat to me.
Yeah.
So the temperature can affect them. So in like the winter, if the eye gel is exposed to cold,
it's not as supple.
It's not as supple. Yeah. So like it takes a minute for that gel material to warm up and create a good seal.
Yep.
So there's a possibility of that. And so like it's really about, if you're going to move somebody, just make sure you've got it secured. And the cool thing about it is you can continually monitor your placement with end tidal capnography, right? That gives you a reading of the CO2 that somebody is blowing off, or the carbon dioxide that they're blowing off. And so we know if we have a reading that we are in the correct spot. So
Got it.
Cool.
Super neat stuff.
Yeah, I think that's a really cool tool of the trade.
100%.
Yeah, we should get some.
I
We have one.
I have some.
All right. So that brings us through that, and then we like to wrap up with a quick student tip of the week from our good friend Jonathan.
So, as you go through your clinical, ride time and your clinical experiences as EMT students, and then start into you've passed your test, and you start in as EMTs. Kind of to our previous conversation about lung sounds, you should be listening to lung sounds on everybody you encounter, whether they're having a respiratory issue or not, because the only way that you're going to get better at discerning those sounds is by listening to lung sounds on everybody. Because as soon as you hear something that shouldn't, like you're going to listen to, let's say 20 sets of lung sounds, and they're going to be fine. And then on that 21st set of lung sounds, you're going to hear something that doesn't sound right. That's good. You're going to be like, I don't know what exactly this is, but this doesn't sound like the previous 20 sets of lung sounds I listened to. So the best way to learn those sounds is to listen to lung sounds on everybody.
Good to know. Yeah, I mean, like,
so that is my.
They don't mention that. You should also be like, not only should you know what the bad lung sounds are, but you should probably know what a good lung sound is.
Yeah.
A baseline.
Right.
If you will, which we will get into in a later episode, the idea of baselines.
Yes.
But yeah, thank you, Jonathan. I think
absolutely.
That's a great tip. And I will certainly be using my stethoscope more, to listen to lung sounds.
Daughter, son, wife, come here.
Yeah, they're all subjects now. I'm just using
absolutely
the blood pressure cuff and the the stethoscope. I was literally doing it last night.
I'm going to grab my dog.
Why not?
Right.
Okay, so thank you all. I think we've definitely chatted a bunch about all the Airway stuff. Stay tuned for next week.
Yes.
Next week we are talking about vital signs.
And our tool of the trade is going to be a sphygmomanometer.
Sphygmomanometer.
You'll get to find out what that is next week.
Yes. So stay tuned. And most importantly, thanks for taking the ride with us. We'll see you next time on the Ride Along.
See you guys.
This podcast is for educational and storytelling purposes only. It is not medical advice or official EMT training. Always follow your accredited instructors and local protocols.
Heartbeats racing in